Good morning, everybody. Dr. Gabriele Jasper MD with Jeremy
Hey, everybody.
on Painless with Dr. Jasper,
That's
Dr.
right.
Gabriele Jasper. Dr. Gabriele Jasper.
Yeah.
All right. What is an interventional pain doc? I'll always like to talk about that.
Mm.
Some people don't know what it is. Hopefully, we have some new listeners that we're going to educate them today. Today's going to be an education. Well, it's always education.
It is, yeah.
Hopefully.
Yeah.
Sometimes we laugh. But interventional pain doc, in my opinion, this is my opinion, is a physician who likes to do or strives to do minimally invasive procedures. Nothing big, nothing intense, no big spine surgeries. We try to minimalize spine surgeries. In fact, we are there as a intermediate or one step before major spine surgery.
Right.
You can call it that. But a lot of times, patients just don't leave my office because we get rid of their pain before they have to get major spine surgery.
Yeah.
But we do have patients that need major spine surgery, and I'll be the first one to admit it.
True.
But you have to exhaust all the possibilities, and the possibilities today, it's so vast. And every 6 months, something new comes out.
Sure.
So, I've been practicing since. Well, I've been a physician since 1987, and I've been practicing pain since 1993. That's when I started my residency in where I learned the beginning part, the evolution of it, the genesis of it.
Yeah.
And believe it or not, we're still in the genesis of interventional pain and probably the genesis of all kinds of medicine.
Yeah.
We're constantly learning new stuff. But what's good about this is I'm going to a course at the end of the month.
Right.
Completely new procedure that I've never done before. But I'm going to get my certificate. I already know how to do it. And I've been doing similar procedures to that, but this one here is a little different. But you have to jump through hoops to be able to be certified in doing it.
Right. Of
And
course.
it's mostly medically legal reasons why.
Yeah.
But it becomes safer when you take courses by professionals.
Right.
And that's what I'm going to do. I want to be the safest I could possibly be. So we find the pain generator, and when we find it, we take the pain generator away, and guess what? The pain goes away.
That's right.
But you got to be able to figure that out, and that's the tough job. Today, I was thinking about what we can talk about, and I think a good topic is the anatomy. People come to my office, patients come to my office, and you tell them I'm going to give you an epidural. They have no clue what an epidural is.
Yeah.
And I can sit here and explain to you what an epidural is. But you're still not going to really understand it. You need visual aids. And I brought a few visual aids in today.
Like, don't you just get that for when you're pregnant? You get an epidural and you're
well, a lot of people say that. Technically, the medicine for labor and delivery it goes into the same spot as the medicine for pain.
Okay.
Because you figure labor and delivery, what are you getting the medicine for? Pain. Right. So that's probably where, I don't know the history that good, but that's probably where it originated from.
Sure.
And we were doing epidurals and spinals for surgeries, actually taken away completely. You could paralyze a patient temporarily for a surgery, putting certain types of concentrations of medication in the epidural space or the spinal space.
Right.
It just numbs you, paralyzes you, depending on the concentration, and the surgeon can operate on you. So I like to talk about a little bit about the anatomy. I'm going to start out with I don't know if you can see this. This looks like it's you can see it pretty good.
Yeah, you can see it real quick.
This here is the lower part of the spine. It's the lumbar spine. It's actually the 3 lower vertebrae of the lumbar spine. You have the sacrum. This is the sacral part. You could see it. Right.
No, in the song, the tailbone's connected to the hip bone.
Well, see, here's the sacrum.
Yeah.
Right. Then you got the lumbar. This one here, the lower one down here is L5. Lumbar 5 vertebrae. Now you can see, I turn it around, and you can see that you have at the actual vertebrae here. It's called the vertebral body,
Vertebral body. Yeah.
right? And then you have in the back part over here, you have the spinous processes. I'm going to test everybody that's listening, so I want you to listen.
Right.
The spinous process, these become very important in understanding what procedures you're going to have.
Right.
For example, here you can see a nerve, this bluish green rubbery substance here is a nerve coming out of what we call
the neural foramina.
The neural foramina.
Yes.
Why? Neural means nerve, foramina means hole or tunnel.
Right.
Right. Now, if I turn this around, you see the spaces in between the spinous processes.
Oh yeah.
Right. You see the space way down in there.
Yeah.
That's the laminal window.
Okay.
Here's the lamina of the spine, and that's going to be important because I'm going to start to talk about different procedures that you can have. And when you understand this is a lamina, here's the spinous process here, right? And then you look in here, here's a central canal, which is right in this area. And there's the spinal cord goes in there. But when you're this far down, you don't have the spinal cord. You have the spinal nerves.
Right.
It's called the cauda equina, which means the horse's tail.
Horse's tail.
Because once it comes out of around the end of the thoracic vertebrae, the beginning of the lumbar vertebrae, you have the ending of the spinal cord. And then it turns into a bunch of spinal nerves, which eventually all start coming out of the lumbar area. You got nerves coming out up higher that go into the thoracic and the cervical, but they just come right out of the spinal cord. These actually come out of with the cauda equina, the nerves that create the nerves, which are called the nerve roots. These are nerve roots, and these nerve roots connect together to form a plexus. And the plexus goes down, and a lot of it forms or creates the sciatic nerve,
right?
And hence the term sciatica pain,
right?
Because when you got pain coming down your leg, you could have pain coming from any one of these nerves. And what happens? These nerves get pinched. They get pinched by, could be a herniated disc. Here's your typical pinched nerve with a herniated disc, right? You could see the hernia right there.
Oh yeah,
right.
The red area, right?
The red dot there.
Yeah,
it's putting pressure on that exiting nerve root. You have an exiting nerve root, and it could also put pressure on a nerve root, which is underneath it, which is called the traversing nerve root. I don't know if you could see that. There it is. There's a nerve root coming underneath it, and that's the nerve. That's a traversing nerve root for this nerve coming out, which it could be. Well, it's a lower one. Let's say this is L4. 5 nerve root. This will be L5 nerve root, and that it could actually have pressure on that nerve root where it's not even near the exiting of L5. Well, that's all pretty intense anatomy. But I explain this to my patients because they need to know, why do they have pain in their foot if they got a herniated disc at L4? Usually pain in your foot is herniation at L5.
Yeah, because if you're a patient and you're before they even come to you and they're feeling all this pain running down their leg, they feel like it's generated from their leg. Obviously, they wouldn't think it's coming up on their back.
Yeah, some patients say, doc, can you just chop my leg off?
Right. I've said those same words.
Yeah, you can. Yeah. See, the reason why you can't chop your leg off, this is pretty good education. You see this nerve here that's inflamed?
Yeah, it's all swollen.
It's not red. Inflammation is red, swelling, and pain. But usually you don't see the color. So this is swollen compared to the one down here. Yeah. Right? Inflammation is swelling and pain because it's got a pinched nerve, right? And the pinched nerve is coming out of maybe there's not enough room in there at all. Right. So it pinches it. So if this is being pinched and it's giving you pain all the way down your leg, you chop your leg off, what's going to happen? You're not going to have a leg, but you're still going to have pain down your leg, which is not there.
Right. Like that ghost feeling, right?
Yeah. It's that's what it's called.
Yeah. Yeah.
But, and that's basically the anatomy. There's another thing I wanted to talk about.
That's like a Twilight Zone thing, though. You know, like, could you just heck off my leg, please, please, please? They do, and the pain's still there, and you can still feel the leg, you know, radiating down the leg. That would be a nightmare. A
Yeah,
nightmare.
it would also be a major lawsuit too.
Yeah.
All right, sure, I'll chop your leg off. Guess what? You still got the pain. Well, I thought it would go away.
I needed a leg.
Anyway, you can see that when you extend back and you extend forward, right? Extend back and extend forward. You can see these joints right here. This joint here, right? This joint here. And then you got the joint on the other side right here. See it moving up and down?
Yep.
That's called a facet joint. It's also called a zygohypophyseal joint.
Wow.
And that, I love that word.
Yeah, I know,
A
right?
zygohypophyseal joint.
It sounds so cool.
Now, what you can have, that's arthritis of the spine. They call it spondylosis in medical terms.
Right.
So if you see something on your MRI, spondylosis, don't get alarmed. It just means arthritis.
Right.
Now, why do we have, this is the root of all evil, I call it.
Okay.
What causes all the pain that you have in your spine? The fact that this disc, which I didn't even talk about yet, you have a disc, this area here. That's a disc, which is between the vertebral bodies. And what does a disc do? Normally, it's about this big. This one's degenerative.
Oh, so when it's okay, so it's degenerative, so it's all thin. This is for the podcast.
Thin and weak.
Yeah.
Thin and weak.
Thin and weak.
That's why when they get weak, you can get all of a sudden get a herniated disc.
Yeah.
Right. So when the disc is normal like that, look how much room you have where the nerve comes out of the hole.
Yeah.
You got a lot of room where the nerve comes out of the hole.
Yeah.
And you got a lot of room between the joints. See those joints?
Right,
There's a lot of
right.
room. But when the disc breaks down, you get that becomes bone on bone, and those nerve roots have more pressure on them because the ceiling and the floor get closer together.
Yeah, yeah.
So the neuroforamina gets smaller.
Right.
And then all of a sudden you got this herniation pop up. Why? Because the disc is weak now and the walls get weak.
Right.
That's called the annulus. You got the nucleus in the middle, nucleus pulposa in the middle, which is in the middle part. You can't really see it here. Here, you can see it better on this one. The nucleus pulposa in the middle.
Right.
And the wall, which is the annulus out here, gets weak. And then all of a sudden it cracks and you lose part of the nucleus comes out and starts putting pressure on the nerves. That's one of the most common reasons why you have sciatica.
So the neuroforamina that's already been like
Compromised
is now
Smaller.
further because of the bulge.
Yeah, because now you have relatively less room in there because there's a bulging disc.
Yeah.
And then what happens is the nerve swells up. So now you have more relatively less room in there.
Yeah.
Because the nerve is swollen. And at this point, real quick, I want to talk to you about what an epidural is. Now you kind of know the anatomy. People say, is this a Band-Aid for the epidural? And I ask them, well, did you hurt yourself? Well, I slipped and fell 2 weeks ago when my pain started.
Right.
So what happens? They probably have degenerative disc disease. That hole's smaller than normal and maybe a little herniation.
Right.
Maybe even some bone spurs occupying space.
I was going to mention bone spurs. Yeah.
Which because you have the arthritis, these joints swell up like people with swollen knuckles.
And that bulge pushes the nerve into those spurs.
The spurs or bone. But let's say a patient never had pain before, down the leg, sciatica pain, and they fell. Well, that's probably a pretty good prognosis unless they recently had a herniation when they fell.
Right.
But most of the time, the spine is the way it is. You know, what they did was they hit that nerve somehow where maybe the spine crushed or something, or the herniation popped out, hit it. They whacked the nerve. Now the nerve is injured. What happens? It swells up. See the difference between the size of this nerve and the size of that nerve?
Right.
It swells up, right? So the idea of an epidural is to decrease the inflammation of these nerves because we give them an anti-inflammatory steroid. Everybody gets different steroids. Some people give expensive steroids. Some people give cheap steroids. Depends on what you get.
You get what you pay for,
You
though,
get what
right?
you pay for.
Yeah.
And obviously, the more expensive ones cost more, and they work better.
Yeah.
Anyway, you drop a little medicine along the nerve, anti-inflammatory. It decreases the inflammation, which means it decreases the pain, within 12 to 48 hours, and we'll shrink this nerve down because that's inflammation is swelling down to this size. And when it does shrink it, look, you're going to have relatively more room in there because the nerve now is one quarter or half the size.
Gotcha. Yeah.
Now they're back to where they were 2 weeks before. If they don't fall down the stairs again, they'll probably do good most of their life.
Yeah.
You know, that's when it's not a Band-Aid. When you say a Band-Aid is just a layman's term. Most of the time, people who don't know what it means, they think that get an epidural is never going to work. Might make you feel better for a day. It's never going to work. But that's not true. It depends on how inflamed the nerve is and how much room is left in there.
Right.
So they asked me if it's a Band-Aid. I said, no. Well, I explained to him what I just explained. If it shrinks down, doesn't touch any of these bony structures or herniated disc or anything like that, it's going to be gone forever until you hurt yourself again, or when you get more degenerative disc disease.
Yeah.
But if there's just not enough room in there for that nerve to live, even after you shrink it down to normal size, guess what? It's going to come right back the way it was.
Yeah.
Right. So then you have to go to the next step, which we'll talk about at another time.
Yeah.
And the next step is usually, in my practice, not major surgery, because we find a pain generator, which could be the herniated disc. I go in there and get the herniated disc out.
Now you said before that when you see something like that, you sometimes would have to send them out to get major surgery. How often do you actually do that? And the flip side, your minimally invasive procedures, how, compared to that, like, which works more often?
Well, the only time I really send somebody out for major surgery of the lumbar spine is if they have major instability.
Right.
That's when it shifts, moves around, because you got such degenerative disc disease. The disc is not adhering anymore. It's just moving around.
Right.
And these joints are moving around. And maybe they're moving around because you have, I didn't talk about the pedicle. This is a pedicle right here, which is a bridge between the joints and the vertebral body. And what that does is it creates a canal, a central canal, which surrounds it by the lamina, the pedicle, and the posterior part of the vertebral body.
Right.
So that creates the central canal where all the spinal nerves and the spinal cord is located. So if you have severe instability, but that's very rare.
Yeah, that's what I was wondering.
It's very rare to have that. I could tell you that probably in the lumbar spine, maybe I've sent out maybe 2 patients in the last year and a half, 2 years, and they technically are patients that just fail what I do, because I find a pain generator, I get rid of the pain generator,
right,
and that's usually all it takes. But these patients just sometimes have chronic pain.
Yeah.
And most of these patients already had surgery. And you get chronic pain sometimes with just having surgery. It's a phenomenon that you just, nobody understands. And I'm in the process of, I got some ideas in my mind on why they have chronic pain in the spine. That's not the discussion here today.
Yeah.
In fact, within the last couple of days, and I'll tell you about it later, on how we could probably get rid of a lot of this chronic pain. With new procedures that have been approved for, an FDA approved for certain things, but it would have to be used in kind of outside the box,
right?
Which would mean off label. That's what they call it. Yeah. Which you can't do as a physician. If you think it's going to work, insurance companies might not pay for it,
right? But
it's something that to consider, to try to figure out if it will get rid of the pain. So that's a lot to do with the anatomy. When we talk about degenerative disc disease, these discs used to be like that, now like that. People wonder why they're a couple inches shorter once they're 60, 70, 80 years old.
Yeah.
Because if you got 5 discs that are losing, quarter cc, a quarter inch, you're talking way more than an inch shorter. And sometimes it's even more than that. The disc goes away and it's bone fuses bone. Vertebral body fuses vertebral body. That's autofusion. You don't have to fuse anybody anymore. They're fused.
Right.
But but that's the anatomy. Now a little bit about what happens.
Now, is that why sometimes when people get older they look like they're shorter and smaller?
Oh yeah,
Yeah.
that's one of the main reasons.
Ah,
They could get compression fractures and lean forward, osteoporosis, even the bones start to crack. These bones here start to crack
right.
and they start to decrease in height. And that happens a lot of times. You see the elderly woman, you see them when they're, 30 years old and they're upright, tall, and then they're all hunched over,
Hunched
and
over,
little
yeah.
when they're older because of osteoporosis. And a lot of women don't realize that, and men too,
Mm.
depending on your hormone levels, that you could do hormone replacement and change all of that. But that's a whole other subject.
Yeah, yeah.
And that's very controversial. But like I said, let's go over some of the things that we could do as far as the epidurals. You could do what they call as a transforaminal epidural, which is needle goes right where the neuroforamina is and bathes that nerve specifically. And at the same time, it pops into the center and bathes the nerves on the inside. So you're really covering two nerves at the same time. And you're covering this nerve not only on the outside, but also on the inside. There's another epidural, which is a intralaminar epidural that goes into the lamina
Yeah.
where that space is in there. But the reason why I don't like that one as much is because if you got a nerve being pinched coming out here that's inflamed, chances are it's not going to reach that nerve.
Yeah.
Why? Because the nerve is, if you squeeze a sausage, right, and you try to put, let's say, dye in one side,
Yeah.
it's going to stay on this side. It's not going to go on to the outside because there's pressure on it. It's got to overtake that pressure. And the reason why it doesn't overtake the pressure is because inside the spinal canal, there's negative pressure above the heart and zero pressure below the heart, which means that if you put medicine in here, it's going to go to the point of least resistance. It's going to go up and down and not this way. If you have any kind of pressure, stricture here, tightening around that nerve, it's not going to overcome that. It's just going to go further up and further down.
Right.
So a lot of times they don't work. But if you have spinal stenosis in the center with inflammation of the nerves in the center, it's going to work to a certain extent. But as far as I'm concerned, I'll say it again, with spinal stenosis, nothing works unless you fix the spinal stenosis.
Right.
There's a lot of ways you can fix the spinal stenosis.
I'm really in awe and just like how well that spine, because like
Well,
you know it inside and out, man. Like
Well,
there's
I
no
should hope
surprises.
so.
Yeah,
I've
yeah.
been doing it for 100 years.
Yeah, but you don't really think just how much and what to expect if it's like here and here. That's brilliant.
Listen, there's a lot of people out there that do what I do that don't really know the spine.
Yeah, that's what I'm
They know how to
getting.
do
Yeah.
injections. They put the injections where they're supposed to be. That's why they don't sit there and tell you the anatomy on the MRI.
Right.
I when a patient leaves my office, they know the anatomy better than most doctors because they need to know and understand. When they understand, they understand the anatomy and they know the anatomy and they know where the pathology is and how it's going to work, the injections or the surgery. They already feel better.
Yeah.
I've had plenty of them say, "Doc, I feel better already. My pain is even better," because they get that positive affect.
Yeah.
The fact that they're happy that there's something could be done. Now, so when this nerve shrinks down to normal size, they're better, right? And of course, if you can't, then you got this herniated disc in there that's pressing on that nerve. We could easily go in and take that out, especially if they're lateral like this way on this side. I come in from the side and come and take it out. In fact, that's my endoscopic procedure.
Yeah.
Endoscopic removal of a herniation.
That's what saved my life, changed my life, everything. I mean, that was it's a magic procedure.
We got probably 2 of them next week.
Really?
We got a lot of them coming up.
Oh, wow.
All of a sudden there's a run of, I guess people want to get taken care of before the summer.
Summer, yeah.
Right. But we have quite a few of those. We did a bunch of them, maybe 3 or 4 within the last month, which worked out beautifully.
Right.
Beautifully. I mean, they don't always work out as you like because patients have different pain generators.
Yeah.
So you get rid of that pain generator, they feel better, but maybe not 100%. And I'm going to say it again. When you got a bad back, you got a bad back. Right. You'll always have a bad back. The question is, give you a better quality of life.
Right.
While you progress into, chronic degenerative disc disease. Because that, you don't stop that.
Right.
That doesn't stop.
Now with pain generators, though, like multiple pain generators, it's like having like 6 radios turned on in the room at different volumes, right? You go
And
for
different stations.
and different stations, but
No, actually, go ahead.
you go for the loudest, the one that's really affecting. You
Yeah.
turn that volume down, but now people are finally hearing the other that was drowned out by the volume of the first. I mean, that's
a good analogy. You know
yeah.
why? Because when I tell people you're going to have 5 different pain generators causing the same pain,
yeah,
that's like having 5 different radios on with the same station.
yes.
So you turn one off, and guess what? You still hear the same music.
Right. It might be a
turn them
slight.
all up.
It might be dimmer, but now you're
That's a
starting
great-
to hear the
I'm gonna
others.
Start using that.
Yeah. Hey, it's
That was a
yours.
good one.
It's yours.
That's no, it's yours. I'm going to mention your name. Now, we always talked about spinal stenosis. Spinal stenosis is tightening of a canal, which is the central canal, which is this canal right in the middle here. See it?
Yeah.
Right here. And what it does, it puts pressure on all the nerves, especially when you stand up. And real quick, remember I told you that the anatomy here, this is a spinous process.
Yeah.
Spinous process. And then you got the intraspinous space in here, which has the intraspinous ligament. You got the posterior spinous ligament. But what happens is when you're like 20 years old, 30 years old, this disc here is this high. And look how separated these spinous processes are, right? And look at the hole in the middle, how much room you got in there.
Yeah.
Now, you have bone here, and you got an opening down in here, right?
Yeah.
Now, what protects that? Spinal canal, spinal cord, spinal nerves. It's called the ligamentum flavum.
Yeah.
The ligamentum flavum, or the yellow ligament, they call it in Europe.
Yeah.
Because it looks yellow when you see it. That ligament is very thick and fibrous, very dense. And it gives you the ability to lean forward, lean back, and twist. If we had all bone, we'd be solid and we wouldn't be able to move. So we're made that way. The problem is when the disc is nice and big, the ligament is flat.
Yeah.
And when the disc breaks down in the front, the ligament collapses and folds like a leather belt. You ever fold a leather belt and snap it?
Yeah.
Right? It makes that noise.
Yeah.
Right? It's flat, right? When you push it together, it forms a loop on both sides.
That's
and
right.
Snap it makes that noise. Well, when you are young, it's like that. And you in a standing up position, as you get older, it goes down and down and down and down, and then that ligament folds, and it puts pressure on all of these nerves.
And it loops out. Yeah. Looping out.
But there's a phenomenon which happens when you have spinal stenosis. When you sit down, you feel better. Why? This opens up. When that opens up like that, because you're almost in a bending position,
Yeah.
it flattens out that ligament, and now you feel good.
Yeah.
When you stand up, this collapses. And when that collapses, it folds and it starts rubbing all of these nerves in the middle. Right?
So when you stand up and you start walking, you're going to start
standing up. You don't even have to start walking.
Oh, really? Yeah.
But it gets worse when you walk because it rubs. And then the patient, this is your typical patient that goes to the supermarket and they get to they go as fast as they can, leaning over till they get to the maybe with a cane, and they get to the shopping cart and they lean on it. It opens up and they feel good.
Yeah. If you go to the ShopRite in Brick, right? Just after you get done with the registers and stuff, and you're about to walk out, there's all these benches, and it's filled with senior citizens. They need to sit down and rest because they've just been snaking their way through the supermarket.
Yeah.
Now they're feeling so much pain because they a lot of them probably do have spinal stenosis, and they take up those benches because they need a breather.
Well, the same thing on the boardwalk. Do you notice every 20 feet there's a bench?
There's a bench, yeah.
We're at the land of spinal stenosis.
That's right.
Somebody who designed that boardwalk must have spinal stenosis.
Must have somebody who has it, yeah.
So this opens up, right? When that opens up, you feel good. Stand up, it collapses, folds, right? I had a guy the other day that had spinal stenosis. I'm asking him how he walks. He goes, "Oh, I can walk. Yes, yesterday I did 2 miles on the treadmill."
Yeah.
Well, you know why he could do 2 miles on a treadmill? Because when you're on a treadmill, they're designed that if somebody has spinal stenosis or gets tired, they can lean forward on
Lean
it,
forward
like a
on
shopping
it.
cart. They
That's
lean
right.
forward and it flattens out and they can go as far as they want.
Yeah.
So it's actually pretty good exercise for somebody who has spinal stenosis. You want to keep those legs stronger.
Right.
And I'll tell you why, because somebody who has spinal stenosis, the legs get weak for two main reasons. Number one, when this ligament folds, it starts rubbing, it puts pressure on the spinal cord, you get a lot less impulses of electrical impulses going to the muscles of the leg. Therefore, not all the muscles are working.
Right.
Right. Number two, you're sitting down and your wife or your husband says to you, let's go for a walk. You're like, no, I don't want to go for a walk. Well, why not? Because I can't. It hurts.
Right.
So that's the other reason they don't want to go anywhere. They don't want to walk. So if you don't want to walk and you don't walk, your legs are going to get weak.
You know, I'm just reminded like all these old jokes back in the 80s when I was growing up, and wives always wanting their husbands to go out with them on the weekend, and like, nah, I can't. I just want to rest. I need to sit down.
Well, that's probably for other reasons.
Other reasons probably too, but still,
Not the spinal stenosis.
maybe the football or something like that, or they want to stay home and you know,
I got a joke, but I don't want to.
yeah, it's a clean show. It's a clean show.
Yeah, it's a clean show. Yeah. Anyway, and probably most of our audience that know me heard the joke 100 times already. But I mean that's and so going back to the spinal stenosis,
Yeah.
how do we fix this? And I do a procedure. It is extremely easy to do.
Yeah.
No general anesthesia. Right? You go home the same day. You get a little twilight, kind of like when you get a colonoscopy. I tell them.
Yeah.
And I'm not going to tell you how fast I could do it, because if the insurance company is listening, they're going to decrease the amount of money they pay you. But it's a very simple procedure. But nevertheless, it's spine surgery.
Yeah.
You know, but don't get alarmed. It's not spine surgery in the way that we think of spine surgery.
Yeah, when most people, when they think of spine surgery, they're thinking of that big giant slice going down their back. I have a scar like that. Before I met you, I had a big laminectomy, and that's what was left. But then when I came to you and I got my minimally invasive surgery, it was just an incision the width of my pinky, and it ended up healing up like a freckle.
Yeah.
Yeah.
Sometimes you can't even find it. But what we do is we put a spacer in here. Remember I said this collapses?
Yeah, yeah.
This collapses. We put a spacer in here, and it doesn't collapse anymore. I had a patient come to my office at the beginning of the week. Monday, we did it 3 weeks ago. The guy, I thought he was like 5'10". I looked at him. I said, "How tall are you?" He goes, "I'm 6'2". And the wife said, I haven't seen him this tall in years. Why? Because of the fact that he doesn't have to lean forward or slouch anymore. Because when this stays open, when you're standing up, you don't have to lean forward anymore.
Right.
When this is like this, you got to lean forward to feel better. But once you keep it like that, the body does not lean forward anymore because the space is already doing it, and you don't see it.
Mm.
You know, it's automatic. You know, and the results are fantastic.
Well, we got Jacob saying that he's also suffering L3, L4, L5 compressing. He says,
Is he my patient?
I don't know. Jacob Basantha. How you doing, Jacob? I'm sorry for your pain, man.
Yeah, I mean, we'll take care of you. I mean,
Yeah.
if you see anything that you might have here, this is what we treat. And I'm going through probably step by step as much as I can on how we treat different things.
Yeah.
You know, I mean, some people are just so bad. Like, for example, if I open up, and another thing, it's good for sciatica pain, because look at the hole with the pinched nerve from the herniated disc.
Right.
Watch how the actual hole gets bigger when you put a spacer in.
Holy cow.
See that?
Yeah.
It gets bigger. So now, without taking out the herniation, which is in there.
Yeah.
See that herniation is in there?
Yeah.
Without taking that out, you just created more room. So why do you have to take the herniation out? If there's more room, you don't have to take it out.
You don't need it. Yeah.
I mean, there's so much pathology by the time you die of ripe old age. Then, if you chased every kind of pathology that you have, you'll be operated on left and right all the time. And if you take you take 100, they've known this for a fact. You take 100 patients that have no pain, and you do an MRI on them, 80% of them have pathology in their spine.
Right.
So you can't. You say anything else?
Yeah. Kat says, how much does poor posture contribute to the wear and tear of these structures?
Well, I mean, I don't know. Why did you go to Catholic school or something? Did you ever get hit with a yardstick?
Right.
For poor posture. I think this is a psychological problem that you have.
Yeah. Well, I mean, even me, like, where I don't so much sit in a chair, I slump in it. Yeah. And
I mean, if you sat all day, 12 hours a day,
sure,
in bad posture, is probably going to mess you up.
Yeah.
But if you have a little kid that slouched over, and first of all, little kids that slouch over, they don't slouch over long. Next thing, they're running around, you give them a chance.
Yeah.
So I don't think poor posture, unless it's for chronically poor posture,
right?
Is if you stay in one position, whether it's good posture or poor posture, it's not good for you. You got to move around. You got to be active. As active as you can.
Yeah.
And like I was, but then later on you'll need a new shoulder, a new knee, a new hip.
Yeah.
Depends on, you got to not traumatize yourself that much. Yeah. But so that's how we do it. We put the spinous process in. But sometimes we have to go underneath or anterior to the spinous process and go in there and take out some more of that ligament, because sometimes it's just not enough. But every time we turn around, there's a new instrumentation to take care of that. Like I got a patient that it's questionable. Should I go in there and grab this herniation, or should I put a spacer in to open up the hole?
Right.
Well, I decided to put a spacer in to open up the hole because he not only has that herniation, he also has the ligamentum flavum, which is thickening. And he has bad facet joints. So you're killing 3 birds with 1 stone when you put the spacer in. You're opening that hole up, you flatten out the ligament, and you're decompressing those facet joints, these joints here that have arthritis. If by any chance it's just not enough and he still has pain going down the leg, we've just taken care of the ligament and the joint. Then I have to go in there endoscopically and just take out that herniation.
Right.
And then the guy's good, or the woman's good. That's how these things are done, step by step. When you come to the Jasper Spine Institute, when you come to my office, don't expect to get fixed once and for all.
No.
One thing, it ain't gonna happen.
Right.
And that's why people go get major surgery, because someone along the line told them, just go get it fixed.
Yeah.
Go to this surgeon. He operates on all the injuries for the giants.
Yeah, it's a one and done procedure.
Whatever but that doesn't, they can be the best surgeons in the world.
Right.
But there's not one surgery you could have. Listen, if you got one herniated disc, pinching a nerve, you do one surgery on them, take that herniated disc off the nerve, and it's going to feel like $1 million. You're going to feel like a miracle.
Right.
Just like what happened to you.
Yeah.
But guess what? You turn around and something else is happening. And the problem is when you get major surgery, sometimes, and the surgeons will tell you, there's not much you can do after that. I got a kid that's 22 years old, and they did a fusion on him.
Oh.
And he had a herniated disc. And the herniated disc I could have taken out easily endoscopically with that little freckle that you're talking about.
Yeah.
But he went to a surgeon. That's what they do. And I don't know why he fused them. The guy had, it was like 2-3 years ago. So he wasn't even 20 years old. You fuse a guy 20 years old or less than 20 years old. What? He was no major accident. He had a little bulging disc because he's a weightlifter, but he's not a heavy weightlifter.
And he's still young enough where that could have
ruined
just
this kid's
healed up.
life.
Yeah.
He's coming to me no matter what I do for him so far. I did epidurals on him.
Oh, man.
I'm in the process. He does have some arthritic changes in that level. I'm going to treat his arthritis at 22 years old, arthritis, because he's got that fusion, it's working. See, if you fuse this another part, if you fuse this part, right, this part doesn't move anymore. See here, it's moving, but doesn't move anymore. But if you have another one on top of it that takes the brunt of everything. This one's not moving underneath. This is taking the brunt of everything. So the joints, the disc, everything
Or wear and tear,
starts
right?
to get wear and tear. And they call that adjacent disc disease. They actually have a code for it.
Wow.
If you got a code for something, the pathology, that means it happens a lot.
Right.
And that's starting to happen to him. So I'm going to keep that. He doesn't need any more fusion as long as I'm taking care of him.
Right.
We'll take care of what happens above and below. But I think this guy has pain just from the surgery.
Right.
And that's where some of my ideas came from on trying to stop people from having pain, post-surgical pain.
Right.
I'm going to do some research on how we could treat that, and I got some ideas.
Yeah.
And I talked to him yesterday. I saw him in the gym, and he's happy about that. But
now we also had a young girl come in recently, and you and Dr. Skoblar worked on her. I did a testimonial with her after the fact, and oh my God, man, she was up and down swearing by you, by Dr. Skoblar, the Jasper Spine Institute.
She was 20? She was 23 years old.
23, and but the tears that were streaming out of her eyes when I was talking to her, and she was telling me everything that she loved that she could no longer do, but now she can do them all again.
Yeah, and it's got that little freckle.
Yeah,
incision.
I mean, here's a 23-year-old girl who loves just to dance.
Yeah,
and she couldn't do it anymore.
And they told her they were going to do major surgery on her infusion, just like that young guy.
Yeah, Jesus. But she feels fantastic. Like she felt like she was touched by a miracle as well.
I don't know. My father tells me don't talk negative about surgeries, the big surgeries.
Yeah, yeah.
I don't talk negative about it. I just try to prevent things that shouldn't happen.
Yeah.
There's unnecessary stuff. This guy was unnecessary. It was unnecessary that a surgeon told this woman, young girl,
yeah.
That she needs a fusion. Well, I like to go talk to him. Why don't you educate yourself?
Yeah.
I got Dr. Radcliffe, who's he's so advanced. He's going to be attending the endoscopic surgeries.
Yeah,
because he wants to learn the good stuff.
Right.
He knows, and he's got a down pat the big surgeries. Right. And I welcome any neuro-orthopedic spine surgeon. You wouldn't be the first one I'm teaching how to do this.
Right.
I've been teaching it for 18 years.
Yeah.
And it's going to get to the point where if it stops being blocked by some of the surgeons, it's going to get to the point where this is the present. And it's not even the future anymore. It's a present that this is what they do all over the world except this country. They do it in Korea. They do it in Germany. They do it in France. They do it in Italy. They do it in Switzerland. They do it in South America. You just name every country.
So why is it the Stone Age in America?
It's the most backward country when it comes to spine surgery. And I'll say it 100 times until they catch up.
Yeah.
I'll keep telling it until I turn blue. And it's all economics.
Yeah, it's money.
It's money. I hate to say it, but I don't want to talk too much controversial stuff.
No.
But anyway, go back to the anatomy. What is the alternative of putting a spacer? Well, you could do a hemilaminectomy or go in there and just take the ligament out. I used to do that endoscopically, which it took a little bit of time to do. It was tedious, but it worked tremendously when you took the ligament out, because you got off of and you could take a little bit of the bone out over here, and it really doesn't harm the patient.
Yeah, because you also we mentioned those bone spurs. You also shaved them out, so they're no longer there after.
If I see a bone spur rubbing up against a nerve, I trim it down.
Yeah,
take it off. Or the next step would be do a hemilaminectomy open from a surgeon, or they take out these bones here, take out the spinous process and the laminate. It's called a full laminectomy. I've seen plenty of those, and why? Because that's what they know how to do.
Yeah,
they got to learn how to do the new stuff.
Now, a lot of patients that have been, for whatever reason, holding back, but coming to you, and have been suffering pain for years and years and years and stuff. That young girl told me it was 4 years she suffered, and she's bouncing around from doctor to doctor trying to find the right one until finally she found you. But for those of you at home that are just waiting, and you're procrastinating because you're so complacent with your pain and you're afraid of more or getting bad news or anything like that. Dr. Jasper, in this one episode of Painless, has shown you what's going on inside your back while you're waiting and procrastinating. And it can only get worse. It's not going to get better on its own, especially if you're in your later years,
or any year.
Yeah, or any year. So, now's the time. Come to Jasper Spine Institute. It's 74 Brick Boulevard in Brick. It's 732-262-0700. And, you'll meet Dr. Jasper or Dr. Skoblar, and they'll educate you just like you were on this show today. And you'll know where your pain is, and you're going to feel relieved because you're with learned and skilled men with those skilled hands, and they're going to take care of you.
Hey, there's a lot of skilled women in our practice too.
But we got Vincenza, also known as Moon Jasper Gem, the amazing psychic. You can find her on Facebook under Moon Jasper Gem, or on YouTube as Moon Jasper Gem. She says maybe you can do seminars on steps to take before getting surgery. Then people and other doctors can attend to increase knowledge on this important matter. Look at that girl. Yeah, she's
That's a good idea.
She's on top of it.
We were doing a lot of those. We did a bunch of them before COVID. Now we're going to start getting back into it.
Yeah. Let's do that.
Now, a little more on the anatomy. Remember, I said here's the sacrum here, and here's the lumbar vertebrae, right?
Yeah.
It's weird that I can see myself there. I can't see myself there.
Oh, I'm sorry. There you go.
Right. So, like I said, there's three different types of epidurals. You got the epidurals that go into the neuroforamina here.
Mm-hmm. You
got the epidurals that go in the middle over here. That's intralaminar. And then a lot of doctors I noticed, and I was trained years ago. We were trained to do this when blind. Well, most of these epidurals were done blind. Not so much the transforaminals. That was that you need to do under X-ray.
Yeah,
you need to do them all under X-ray, under fluoroscopy. But we were trained when I was trained in the Stone Age to do all of these, especially the caudals. These caudals go into the little hole down on the bottom here, and the caudals were the easiest ones to do, and we used to do that for a lot of infants that had surgery, that would get rid of their pain post-operatively.
Right.
Make them more comfortable. As anesthesiologists, before we put them to sleep, we give them a quick caudal. But anyway, if they can have hernia repairs or any kind of abdominal surgery, we would do that, right? But there's a lot of doctors that do epidurals here, which will work if you have very little wrong with you, like somebody in their 20s have a little bulging disc or herniation. Once you get a little steroid in the spinal canal, it's going to help and it's going to work, right? However, when you have somebody that has a spinal stenosis up here, way up here, and you give them medication down here, it's not going to work. To be fair, if you got moderate severe spinal stenosis, no matter where you get the injection, it's not going to work.
Right.
But maybe that's why they do it over there, because it doesn't matter that much, because it's just not going to work. And a lot of times it comes down to the fact that the insurance companies will not pay for the next step, which would be a spacer or something like that, or laminectomy, hemilaminectomy, until you do conservative treatment, which would be considered epidurals and physical therapy, aspirin, Motrin, Aleve, stuff like that. That's considered conservative treatment, and you need to do it. But I don't do caudals anymore. The only time I do a caudal is if somebody has some spine surgery, and there's you could actually see some or suspect what scar tissue in the central part of the canal and in the neuroforamina that's putting pressure on the nerves, just the scar tissue. So we can go in there, put a catheter up to this area, and then we could drop what they call certain type of medication, what they call lyses of adhesions, right? It'll sort of dissolve some of these scar tissues theoretically, and it works. Sometimes it doesn't, sometimes it does.
Yeah,
and you need to do that periodically. That's the only time I would go in there with a catheter to get to where the pathology is. There's very little pathology down here.
Right.
But hey, listen, continue to do those caudal epidurals so that when it doesn't work, the patients will come to me.
Yeah. That's right.
Yeah. But what else? What else we could talk about as far as based on the anatomy, how we can help you? All right, I got a good one.
What's that?
We talked about the arthritis in these joints here.
Oh yeah.
There's a joint there. There's a joint there. There's a joint down in here, right? These are the facet joints, the zygohypophyseal joints that when you have degenerative disc disease, like I told you, they cause pain. Now, if you notice that I put a little black line right there.
Yeah.
See that? I put that there with a pencil or a pen. Right in that groove there, there's what they call as a medial branch nerve. And people need to understand that it's a very simple procedure. If you got pain in this joint here, you got a nerve that comes out of that joint, goes into this groove, and goes through the spinal cord to the brain, and it brings pain sensation to your brain from that joint. So the only reason you know that you have pain in that joint is because that nerve is like an extension cord. It brings it right to the brain. It tells your brain you got pain there. What we do is we can heat this nerve up with a special needle, put the tip of the needle right on that nerve under x-ray. Very simple, and we got to connect it to a generator. We heat radio frequency generator. It's called ablation. Some people will understand. You've had it.
Yeah.
It's ablation of the medial branch nerves. You heat it up at 80 degrees Celsius for 90 seconds, it stops working.
Oh, it's magic. It really is.
Stops working.
I love it. I love
and
it.
You don't feel the pain.
It's one of my favorite things that I get done when I need it, but I haven't needed it for 2 years now, knock on wood. And like I still roll out of my bed without a grunt.
Well, it takes, what it does is the heat turns it denaturizes a protein. It doesn't completely singe the nerve, but it denaturizes a protein like you fry an egg. You got to the clear part of the egg turns white. That's protein changing structure. And when it changes structure in the nerve, it does not what they call propagate electric impulse. Right. Electric impulse can't go through there. And because of that, it may grow back. It could grow back at 6 months. It can grow back in a year. The average person grows back in a year. Just do it again. Like you, for example, yours did not grow back yet. It's been 2 years. I met people 8 years. Yeah. And never grew back.
Wow.
It depends how fast your body heals. But that's a great process. The one of the downsides of that is we used to burn every nerve that had arthritis. That every nerve that innervated came out of a joint that had arthritis. But then the insurance company came up with a rule you could only do the 3 lower nerves, which, the 3 lower nerves you have for each joint is innervated. In other words, there's 2 nerves coming out of it, one above it and one below it.
Right.
So you have to get both of those nerves in order to stop the pain from that joint. So if you're only doing 3 nerves, right?
Yeah.
You're doing this one. Or let's look, it's easier this way. You're doing this nerve here, you're doing this nerve here, and you're doing this nerve up here, right?
Okay.
You're only treating this joint and this joint. So a person has 5 level or 6 levels that have arthritis. You've only treated 2 levels.
2 levels. Yeah.
So you got another 4 or 5 levels to go. Right? So people come back sometimes and say, Doc, I don't feel any better.
The radios again.
Yeah. The what?
The radios again. You take care of a couple, you turn the volumes down, but you're still hearing.
I always tell them it's like having a kindergarten class with 50 kids in it.
Right.
Screaming, and you're trying to keep them quiet. You only manage to keep 10 of them quiet.
Right.
It's still going to be pretty loud in there.
Yeah.
But what we could do is you need to explain that to the patients beforehand.
Right.
You might get 10% better. You might get, if it's 20% of the pain generators, you might get 20% better.
Yeah.
If you want to get 100% or close to it, you got to do all of them. But we're allowed to go in later on and do it once we see it's not enough. A lot of patients don't know that. A lot of physicians don't know that. So that's another way we can treat patients. It's all anatomy, understanding anatomy and how to treat it and how to make a diagnosis.
Yeah.
And the way we make that diagnosis is people who have arthritic pain. You want to compare it to, let's say, spinal stenosis pain. People who have arthritic pain are the people that have more pain when they get up in the morning. And as soon as you move around a little bit, some of them say it's like a ceremony when I get up in the morning. I get up, I sit at the side of the bed, I take an aspirin, Motrin, Aleve, or Percocet, and I go back to bed, wait an hour, and get up, and I'm okay.
Right.
Or they'll say, I don't want to take any of that stuff. I get up and I suffer. I go make my coffee. I sit down. It hurts. I walk to the bathroom. It hurts. After about an hour and a half, it feels better. And if I walk too much during the day, it hurts again. That's arthritis of the spine. So most of the people who have arthritis of the spine are the people who have it in the morning.
Right.
People who have spinal stenosis usually feel better in the morning. They just can't walk far and they can't stand long.
Yeah.
People who have pain in the morning, that's bad. And the same person can't walk far and can't stand long and got to lean over, got to sit down, have spinal stenosis and arthritis of the spine.
Right.
This is the way you make the diagnosis. It's not rocket science.
No.
But that's it. That's you think anything else I could explain? What do you? Oh, compression fractures. A compression fracture is something that we can get rid of the pain very easily. This bone here, which is a vertebral body, breaks. It cracks.
Yeah.
How? An older woman most of the time with osteoporosis. It cracks when you fall. I had a lady that came in my office who tripped over the cat, hit the wall, and went down.
Oh.
Relatively young lady, maybe 50, and she cracked a bone. Now, that's not because of osteoporosis, maybe a little osteopenia or something. Right. Little weakness because she's not young, and she cracked a bone, and we fixed it. She felt great for about a week. Now she's coming back with pain again. Now, she might have cracked another one, but highly unlikely. But I noticed that she had a herniated disc around the same level, which was probably caused by the fracture.
Right.
I'm going to go in and give her a shot around the herniation, and she's going to hopefully feel better because the nerve is swollen like this and inflamed.
Yeah.
But we fixed this. We fixed the crack. How do we do it? We put a special needle that goes in through. It's a bigger needle than normal. It goes in through here. It goes in through this bridge called the pedicle into the vertebral body. And we inject cement, epoxy, whatever you want to call it, and it fills in the cracks. Because what is the pain? Where's the pain coming from? It's coming from the fact that the bone is crunching.
Right.
So if the bone is crunching, it hurts. Whereas it's like if you break an arm, you break a leg. It's painful as hell. But once you go to the emergency room and they set it and they put a cast on it, doesn't hurt anymore because now it's not moving, it's not crunching. The same thing. The majority of my patients that I fixed that compression fracture would be either vertebroplasty or kyphoplasty. They get off the table pain-free after having severe pain. And that's one of the worst pains that you could have that I've seen in my practice.
Right.
And there's not too many people do it. It's very intimidating to do that because one slip up, a person could become paralyzed. So a lot of physicians don't do it because of the fact that it's not a high risk, but it can happen. Well, it can happen with any kind of spine procedure. You become paralyzed, weak, you could die in any kind of procedure.
Sure.
Even a appendectomy, whatever it is, something bad could happen.
Yeah.
Even if the doctor does everything perfectly okay.
Yeah.
Within the standard of care, it still could happen. That's why you sign consents.
Yeah.
And nobody will operate on you, do anything unless you sign a consent. What time is it?
We're done.
We got like 2 minutes to go.
2 minutes, yeah.
All right. So we're located on 74 Brick Boulevard, Brick, New Jersey. We're open 5 days a week. Somebody's always there. If you have an emergency phone call, even if you want to make an appointment on a weekend, you can call. Chances are somebody's going to get back to you Monday morning or maybe even during the weekend.
Yeah, definitely.
Probably unlikely during the weekend, but if it's an emergency, of course, our recording says call 911.
Sure.
but during the week, there's always somebody who will speak with you. I don't know why. Sometimes I call doctors, even for myself, and I leave a message and they never call you back. I don't understand that.
Yeah.
You know, we call our patients back, no matter how light, how frivolous it is.
Oh, yeah, because
we
we
will
know
call them back.
We know your pain's
if
important.
you need to talk to me, Dr. Scobler, we will talk to you.
Yeah.
And we spend time with you. So give us a call at 732-262-0700. And you can get us on what is it? Jasper MD.
At JasperMD.com. JasperMD.com.
Jasper MD. And you can see all of these on YouTube, and you can listen on the radio tomorrow and hear it probably around 6, 7 o'clock in the morning.
Yeah.
On what is it?
It's 104.1 FM. It's Cat Country.
All right, good.
Yeah.
Well, thank you very much. Now you know the anatomy.
That's right. That's right. And like we said, for more information about Dr. Gabriele Jasper, please go to jaspermd.com, and you can make an appointment by dialing 732-262-0700. All right, Doc. Take